Good morning, everybody. I hope you're having an amazing day today. So, before we begin our spinal cord lesions and let me continue and finish, I would like to request you to subscribe to the channel to stay tuned for all the new videos that are going to come up every single day, which is going to cover all the pathology in the major systems. Alright, let's continue our most important spinal cord lesion, which is Friedreich ataxia and degenerative disorder of the cerebellum and spinal cord. Remember, this involves cerebellum and the spinal cord. Degeneration of the cerebellum leads to ataxia. Degeneration of multiple spinal cord tracts leads to loss of vibratory sense and proprioception, muscle weakness in the lower extremities, and loss of deep tendon reflexes. These are the reflexes that a neurologist would check in the general examination whenever a patient's coming in an outpatient clinic. Next is fact about this one is it's autosomal recessive due to expansion of an unstable trinucleotide repeat GAA in the frataxin gene, and the frataxin is essential for mitochondrial iron regulation. Loss results in iron buildup with free radical damage. It presents in early childhood. Patients are wheelchair-bound within a few years, associated with hypertrophic cardiomyopathy. So this is all about the spinal cord lesions. Let's move on to the meningitis, starting with the basic principle. Inflammation of the leptomeninges. Meninges consist of three layers, dura, arachnoid, and pia, as we all know, and they lie between the brain and the skull. Pia and arachnoid together are termed leptomeninges, and because this is a thing about meninges, so here we have some tracts: spinothalamic, pain and temperature sensation. It's the name of a tract, spinal cord tract. Dorsal column, medial lemniscus, pressure, touch, vibration, and proprioception. This is what it does. Lateral corticospinal, it deals with the voluntary movements. Hypothalamo-spinal, sympathetic input of the face. So it's divided into first order neuron, second order neuron, and third order neuron. For the first tract and the first order neuron, we have peripheral nerves to posterior horn. Cell body is in dorsal root ganglion, but in the second order, it arises from posterior horn, immediately crosses over in anterior while commissure, and ascends via the spinothalamic tract to thalamus. And the third one, of course, is thalamus to cortex. And the second one is there's peripheral nerves to medulla. We have dorsal column. Cell body is in dorsal root ganglion, arises from medulla, crosses over, and ascends via the medial lemniscus to thalamus. Thalamus to cortex. This is like first, second, and third. Let's go with the flow and move on to the third track, which is the first order neuron goes for pyramidal neurons in cortex, descend, cross over in medullary pyramids, and synapse on the anterior motor horn of the called upper motor neuron. Second one arises from the anterior motor horn and synapses on muscle, which is lower motor neuron. And the third one, of course, there's none. And the fourth track arises from the hypothalamus and synapses on the lateral horn at T1. Second order neuron arises from lateral horn at T1 and synapses on the superior cervical ganglion, and it is, of course, sympathetic. Third order neuron is superior cervical ganglion to eyelids, pupil, and skin of face. So these were the four tracts you would have to remember. Next up, we will talk about the most commonly due to an infectious agent this is about meningitis. The names are given: Group B, Streptococci, E. coli, Listeria, monocytogenes. This is happening in neonates. And meningitis is children and teenagers specific, Streptococcus pneumonia, adults and elderly, H. influenza, non-vaccinated infants mainly. Now, Coxsackie virus, children, fecal-oral transmission. Remember, the route of transmission is fecal-oral. Fungi, immunocompromised individuals, presence with classic triad of headache, nuchal, rigidity, fever, photophobia, vomiting, and altered mental status may also be present. So be vigilant. Diagnosis is made by a lumbar puncture, which is very common in neurology clinics. Sampling of our CSF performed by placing a needle between L4, L5. We have to just remember the levels. It's the level of the iliac crest. Spinal cord ends at L2, but subarachnoid space and coda equina continues to S2. Layers crossed include skin, ligaments, epidural space, dura, and arachnoid. CSF findings for bacterial meningitis, you would see neutrophils with decreased CSF glucose, gram stain, and culture often identify the causative organism. Now, viral meningitis, you would see lymphocytes with normal CSF glucose, fungal meningitis, lymphocytes with low CSF glucose. Complications are usually seen with bacterial meningitis. You would see death because herniation secondary to cerebral edema, hydrocephalus, hearing loss, and seizures, sequelae related to fibrosis. So that's something you would see here. Next is cerebrovascular diseases. The basic principle would go like neurologic deficit due to cerebrovascular compromise, major cause of morbidity and mortality due to ischemia. 85% of the cases are ischemic, or hemorrhage, which is 15% of the cases. So neurons are dependent on serum glucose as an essential energy source and are particularly susceptible to ischemia, undergo necrosis within 3 to 5 minutes. The global cerebral ischemia. Cerebral ischemia is to the brain. Major etiologies are low perfusion, like atherosclerosis, acute decrease in blood flow, cardiogenic shock, chronic hypoxia, anemia, and repeated episodes of hypoglycemia, which would be insulinoma. That's how you would see. Clinical features are based on duration and magnitude of the insult. Mild global ischemia results in transient confusion with prompt recovery, and this is the pale infarct cortex, and on the right side you will see a lacunar infarct. Now, severe global ischemia results in the diffuse necrosis. Survival leads to a vegetative state. Moderate global ischemia leads to infarct in watershed areas lying between regions fed by anterior and middle cerebral artery, and damage to highly vulnerable regions such as pyramidal neurons of the cerebral cortex, layers 3, 5, and 6, leads to laminar necrosis. Pyramidal neurons are of the hippocampus temporary lobe, important in long-term memory, and Purkinje layer of the cerebellum integrates sensory perception with the motor control. That would remind us of ischemic stroke, where the regional ischemia to the brain that results in focal neurologic deficits lasting greater than 24 hours. If symptoms last less than 24 hours, the event is termed as transient ischemic attack, TIA, which is again very high yield. Subtypes include thrombotic, embolic, and lacunar strokes. Like thrombotic stroke is due to rupture of an atherosclerotic plaque. Atherosclerosis usually develops at branch points, like you would know. The second one results in the pale infarct at the periphery of the cortex. Embolic stroke is due to thromboemboli, as given the name embolic. Most common source of emboli is the left side of the heart, atrial fibrillation. usually involves the middle cerebral artery, results in a hemorrhagic infarct at the periphery of the cortex. Knowing this, you should definitely work hard on neuroanatomy. It will definitely help you map out all the structures of the brain that are being discussed here. So, back to lacunar stroke. Occurs secondary to highly arteriosclerosis, a complication of hypertension, which we all know, but most commonly involves lenticulostriate vessels, resulting in small cystic areas of infarction. Involvement of the internal capsule leads to pure motor stroke, and involvement of the thalamus leads to pure sensory stroke. So this is something we have to remember. Ischemic stroke results in liquefactive necrosis, eosinophilic change in the cytoplasm of neurons. Red neurons are given, I'll show you later. It's an early microscopic finding, like 12 hours after infarction. Necrosis within 24 hours. Infiltration by neutrophils, day 1 to 3. And microglial cells, day 4 to 7. Gliosis, 2 to 3 weeks. Then ensue, and then the results in the formation of a fluid-filled cystic space surrounded by gliosis. And these are the pictures for the brain infarct, red neurons. This is basically how you would see the cyst forming. So that's all for the cerebrovascular diseases for today, and the rest of the CNS pathology would be discussed in the next video. So stay tuned, like and subscribe to get notified as soon as a new video is uploaded. Thank you very much and have a great day. Goodbye.